Hello everyone, it's Dr. Jack, and let's begin our presentation, the extended vignette questions. And I want to tell you that we have our two goals. I have two goals for us for this presentation. One is we are certainly going to be, in these questions reviewing the psychiatric content, that it's relevant to your exam. But we're also going to be focusing on you as the test taker and kind of see what we can learn about you and your response to certain exam questions. And it'll become clearer what I'm talking about as we get through them. Now, please note that some of the questions that I'm going to be presenting to you are perhaps a little bit more difficult than they would be on the real exam. Not that they're esoteric, but maybe they're even a little bit more kind of unclear, than you would expect to see on the exam. But I did this intentionally, again, to help us focus on you as the exam taker. What I'm trying to do is what's sometimes called stress inoculation. I want you to pay attention to how you're responding to these questions so that when you're in your real exam, then you will already be kind of attuned to your own responses and reactions and neither be surprised by them nor worried about them. And again, it'll become clear as we go through this. Now, in this presentation, we're doing two different vignettes. We're starting with vignette number 1, and our patient case study is Jeff. So Jeff is a 42-year-old man who presents with complaints of anxiety, inattention, and financial pressure due to long-standing unemployment. He requests marital counseling. He has been married for 19 years to Lori. Lori reports that she has had, quote, one foot out the door for the last few years and states, quote, I am tired of his attention-seeking attitude, his anger and blubbering when he doesn't get his way, his holding grudges, and his inability to keep a job and contribute to the family. As a child, Jeff experienced emotional and physical abuse by his father. At first, Jeff and Lori were happy when they were first married. He idealized her and she loved his attention. Over time, his neediness began to chip away at her desire, and she would more frequently reject his sexual advances. This brought on Jeff's fears of Lori leaving him, which increased his overall anxiety. Jeff reports experiencing fluctuating depressive and anxiety symptoms for as long as he can remember. He has no history of suicidal behaviors, but has often thought of hurting himself or doing something dangerous that might lead to injury or death. He also experiences periods of increased agitation and irritability. Jeff's spotty employment history is due to his impulsiveness, inability to get organized, and frequent bad judgment. Lori has often stepped in to smooth out Jeff's conflicts with his bosses, family, and neighbors, and she complains about how Jeff remains helpless, like a little child, quote unquote. Jeff tells Lori that he will, quote, fall apart if she divorces him. All right, our first question. Criteria to which of the following psychiatric disorders is Jeff most likely to have met as a child? And you are to choose two. Attention deficit hyperactivity disorder, autism spectrum disorder, conduct disorder, oppositional defiant disorder, or separation anxiety disorder. Now, while you're answering this question, this is again, focusing on our second goal about you, the test taker. I want you to, right now, as you're thinking about the answer, maybe you've already come up with the answer, maybe you're still deliberating, I want you to pay attention to your own emotional response. Just in a word or two, you could jot it down. You can even, why don't you send it, in the chat, send it to us, and Michael can then kind of give me the list, and I'll go over that with you. Of course, you can be thinking like, oh, this is so easy, I feel great, this is fun, right? Or you might feel, frustrated, maybe even angry. Angry because, you have that sense of uncertainty. Maybe you're angry at me for writing such a bad question, or at the real exam, angry at whoever the ABPN or whoever wrote those questions, right? Or maybe you're worried, concerned. Maybe your thoughts are running away with you, like, oh my God, when is my exam? Am I going to be prepared? This is not what I was expecting. Whatever it is, it's normal, it's natural, and it's common. I assure you, whatever you're feeling, it's common. Maybe the fun part, that's the least common response I would imagine getting. Now, before I'm going to show you the answers now. ADHD and separation anxiety disorder. But I'm not going to explain or justify just yet, because my explanation at this point would impact your answers to the following questions. Last thing I want to say before I move on to question 2 is I purposely loaded this vignette with a ton of different diagnostically focused questions. On the real exam, you would not expect, excuse me, to have like 5 questions in a vignette focusing on diagnostic issues. I'm doing this on purpose because I'm also trying to demonstrate to you how, one vignette, how it could be massaged to spit out many different kind of questions. Because one question I often get is like, Jack, okay, I got it. I read the vignette, I got it, but what can they ask me about it? And so I'm kind of demonstrating all the different ways I can use that vignette to come up with a lot of different questions. I could have come up with 10 more that really focus on just diagnosis, even before getting into assessment or treatment. Our second question: which of the following personality disorders most closely matches Jeff's emotional and behavioral response patterns? Choose 2. Antisocial personality disorder, avoidant personality disorder, borderline personality disorder, dependent personality disorder, or histrionic personality disorder. Okay? Let's give you a moment to choose. And also, once again, let me ask you to kind of pay attention to your own emotional response, cognitive and emotional response. What are you thinking? What are you feeling? Jot it down. If you're not jotting it down, at least really remember it in your mind. That 1 or 2 words. Okay. I chose borderline personality disorder and dependent personality disorder. One other thing I can add here. Now imagine that these are the questions you were confronted with, but you weren't provided with the right answer at 20 seconds later. In fact, you never got the right answer. 6 weeks from now, from you taking the exam, 6 weeks later, you're getting the results whether you passed or you failed. And even then, you're not getting the answers to any of these questions. Imagine how that would feel. I know how that made me feel, has made me feel in all my times taking exams. You could probably guess, but I want you to think about that. What are we doing? Again, we're getting used to and identifying our responses right now, because this is not the real exam. Then you're likely to have the same kind of response, maybe more powerful or maybe less powerful, because you already have gotten kind of used to it, right? You're learning to tolerate it better. But now you're going to be less surprised by your response at the real exam. Third question: regarding Jeff's emotional and mood symptoms, from the following options, which of the following are the most likely psychiatric diagnoses on the differential diagnostic list? Choose 3. Bipolar 1 disorder, bipolar 2 disorder, cyclothymic disorder, major depressive disorder, persistent depressive disorder. Now how do you feel? Are you feeling frustrated? Are you angry? Do you want to reach across the screen and kind of tug me by the throat? Well, this is what I chose, the 3. Bipolar 2 disorder, cyclothymic disorder, and persistent depressive disorder. And you can think about that. Why did I do that? Maybe you're going to, no matter how much you think about it, you may still think, I'm wrong, this is dumb, I chose the wrong ones. But at least give me the benefit of the doubt to start with, and think about why I chose those, as opposed to, for example, why did I choose persistent depressive disorder rather than major depressive disorder? Next, which of the following psychiatric disorders should be most carefully assessed for based on the likelihood of their presence? Choose 3. generalized anxiety disorder, intermittent explosive disorder, schizophrenia, somatic symptom disorder, or substance use disorder. Okay? Again, pay attention to your own cognitive and emotional response. And then also, third, pay attention to how you're choosing. And then if you're feeling stuck, why are you feeling stuck? And how are you responding to that feeling of stuckness? Now, if this was the real exam, would you just choose those three and move on? Or would you want to kind of hang out here longer? Now, in these extended vignettes, you can tag them for review. But the other half of the exam, without these extended vignettes, you can tag it for review. Would you be kind of considering that? In this case, if you could. So I chose generalized anxiety disorder, intermittent explosive disorder, substance use disorder. Now, one little tip here that I couldn't tell you without kind of spoiling the upcoming questions is sometimes you can use, it's easier to use the approach of addition, where you're adding on. You have to choose three. So you're kind of adding into your basket. You need three disorders in your basket. You start with 0, and you're kind of adding them in until you reach 3. But let's say in this case, and this might actually be a good example of that, maybe you start the other way, and you have a basket filled with 5, but you can only have 3. Maybe it's easier to subtract, right? Maybe in this case, maybe it's easier to subtract the ones that are least likely, like schizophrenia and a somatic symptom disorder. You see, you can have the additive approach. You start from nothing and you add them in, or subtractive. They're all in, and then you take the least likely ones out. Notice also, I mentioned the word likelihood. I've been repeating it. This is the way a lot of the questions are written. It's the most likely, right? The most likely next step. What's the, kind of the best next step, for example, if it's an assessment or treatment plan. So you notice it's never kind of definitive. It's not what are the right diagnoses. It's like what's the likelihood, or what are the most likely diagnoses. And that's very important. And if you pay attention to that, it may actually help bring down that sense of frustration and stress, because you may be finding, as you're paying attention to your response, that you're wanting a certainty, a definitive next step in assessment, or definitive next step in treatment, or definitive diagnosis, or working diagnosis, or whatever, or the definitive differential list. You're not getting definitiveness. You're not getting certainty, as I think you're probably finding. Question 5. Which of the following rating instruments would be most appropriate to use in assessing this patient, Jeff? The Brief Psychiatric Rating Scale, the Brown Attention Deficit Disorder Symptom Assessment Scale for adults, the Rumination Response Scale, Somatic Symptom Scale, and the Vanderbilt ADHD Parent Rating Scale. Which ones make the most sense? Well, I chose these. Brief Psychiatric Rating Scale. Now, Brief Psychiatric Rating Scale, it's very, very commonly used. It's kind of comprehensive. It was really designed more for psychotic symptoms, but it also can assess depression, anxiety, hostility, irritability, things like that. So it's often used as a kind of broad spectrum screening tool. And then, of course, right, wasn't there some evidence here that Jeff may have had ADHD or still has? Yeah. So you have 2 scales here that have to do with ADHD. The Vanderbilt ADHD Parent Rating Scale, that is certainly, filled out by an adult, but it's not about the adult. It's the parent of the minor child, right? So, of course, then the Brown ADHD Symptom Assessment Scale for adults is a lot more sensible than the Vanderbilt. Rumination Response Scale, somatic symptom scale, you know, those are very narrow spectrum scales, rating instruments, and we don't really have strong evidence of Jeff having either rumination or kind of somatic preoccupations. All right, now let's do Jeff part 2. Upon further questioning, you learn that similar cycles of Lori's threats and Jeff's promises and initiation of therapy have happened several times in the past, but that Jeff has never followed through in the therapy for long. When you gently probe Jeff about this, he looks both ashamed and irritated and blames his lack of follow-through on his poor impulse control, his bad judgment, and his bouts of unemployment. He then confronts you by saying that those are the reasons he's here. If he were perfect, quote unquote, he wouldn't be talking to a therapist. That's some pretty strong comeback, huh? So, given the information about Jeff's case you've learned so far, which of the following psychosocial treatments would most likely be beneficial to Jeff as initial treatment? Choose 3. Anger management therapy, dialectical behavior therapy, motivation enhancement therapy, psychodynamic therapy, or social rhythm therapy. Okay? Now, remember the additive versus the subtractive approach? Actually, for me, this would be a good one to use the subtractive approach. For me, it would be easier to choose the 2 I don't want to take home with me rather than the 3 that I do. Anyway, my response has been anger management therapy, dialectical behavioral therapy, and motivational enhancement therapy. All right? Social rhythm therapy, that's used in bipolar disorder, so that's kind of reasonable. We didn't learn anything, though, specifically, and here's an explanation here. He may indeed have bipolar disorder, so I'm not surprised that some of you chose that. That is not a bad choice. On the other hand, we didn't really learn anything about him being kind of having circadian kind of disturbances, you know, or anything like that, right? There just really wasn't any positive evidence for that. Psychodynamic therapy, that could certainly be, you know, a very sensible approach, but maybe not to start with. You know, it seems like, you know, maybe we'd want to get more kind of directly into what's going on. He certainly has kind of anger management issues. The motivational enhancement, why that? Well, you know, he's had therapy several times and dropped out. So the good news is he is coming back. In fact, he wants to come back right now. But his chances of continuing through the therapy, and therapy is not easy, it's often not pleasant. You have to either do homework assignments you'd rather not do, or you have to talk about things that are kind of painful and kind of reflect upon yourself and your shortcomings and all the bad things that happen in your life. So this would actually be maybe a very good time with Jeff to start motivational enhancement. While he is coming, he's motivated, but his motivation, we could imagine, will fall off, or something else, because something else can interfere, and because therapy itself is kind of unpleasant. And then, of course, I think everyone chose, I'm looking here, dialectical behavioral therapy, because he certainly seems to have some evidence. It's not definitive, but there's positive evidence that he might have a personality disorder, borderline personality, or dependent, right? Now, going back to my first kind of question about, like, what could he have met as a child? So the concept here is, and I'm going to talk about this in our next presentation because I had a specific question about it, and I'll kind of more formally go through it, but just to highlight, go with the answers for which there is positive evidence. So we have evidence from Jeff, you know, really being, you know, one of his fears is fear of abandonment. Now, what kind of individuals have that fear of, you know, kind of being left or being left alone? Well, patients with borderline personality disorder, right? Fear of abandonment. Also, people with dependent personality disorder. and also people with separation anxiety. So this is kind of like, kind of rethinking it, that, oh, maybe this is separation anxiety. And I think for those of you listening to me who are adult psychiatrists or non-child adolescent psychiatrists, you may not be fully aware that, separation anxiety can occur at all age ranges. It's not only limited to children who are, kind of have school refusal, right? It can happen from adults. Now, if the adults have it, it's usually because it started in childhood. It doesn't arise usually de novo during adulthood. All right. Now, Jeff responds that if he were perfect, he wouldn't be talking to a therapist. What would be a reasonable response from you? That he is being defensive and you didn't mean to hurt his feelings? That he can't talk to you in such a condescending way and that he will not be invited back if he continues to talk this way to you? Or that his past psychotherapy failures show he's not a good therapy candidate and that medications are a better approach for him? Or that you want to learn about his challenges in previous therapies so the two of you can decide on an approach with a higher chance of success? Or that you want him to follow your instructions now on progressive muscle relaxation to help him calm down? Now you got to choose one. So which ones did you choose? Wonderful. It's like 96% chose D. Very good. Now, this question wasn't that challenging to you, and it wasn't that difficult either, but this is reflective of the kind of questions that are more kind of like psychotherapy or process-oriented on the exam. They tend not to be too hard, and the only non-board reflective part here is I think my response options are too long, but other than that, it really is related to, reflective of the board exam. All right, next question. Which of the following approaches during initial sessions could best improve Jeff's success in psychotherapy? Choose 3. Agree upon treatment goals. Explain reasoning behind the techniques and exercises of therapy. Or have Lori drive Jeff to the clinic to ensure he attends. Or request payment for a full course of therapy at the start. Set explicit expectations for therapy. All right. Which 3 are you going to choose? Good. I think the most common ones you chose are these, in fact. Agree upon treatment goals, explain reasoning, set explicit expectations for therapy. And this is, kind of 3 kind of hallmark approaches to take in terms of treatment success. People have to know what they're getting into. You have to have agreement, discussion and agreement on the treatment goals, and just kind of so they have clarity on what to expect. Because for you, it may be old hat. For the patient, they may be afraid that you're going to be delving too deeply into whatever their sexual fantasies. They have no idea. Maybe all they know about psychiatrists is what they've seen on Alfred Hitchcock movies or something like that, and they kind of fear the worst. Having Laurie drive Jeff to the clinic to ensure he attends. Some of you chose that. I could see maybe like for some really short-term kind of approach, but I would probably, for myself, I probably would not do that because I would just see that as enabling and as just, not really addressing the underlying issue, right? And in a way, it's just kind of continuing Jeff's and Lori's kind of codependent and dysfunctional relationship. Next question, you ask Jeff if he has any thoughts, intentions, or urges to act violently right now. He convincingly says he does not. What additional assessment steps would you take to best establish Jeff's risk of violence towards others now and in the future? Choose 2. Assess whether Jeff has a history of substance use. Assess if he has ever acted violently in the past, and if so, under what circumstances. Or ask Lori about Jeff's history of violent behaviors and her present level of concern. Or ask if Jeff's abusive father is still living. Or ask Jeff to sign a no-harm contract with you. got to choose 2 out of these 5. All right, I'll give you, I see their answers are coming in. Good. Now, see, this one's tough because here's another instance where you might be feeling really frustrated, and you're like, no, I don't want to choose 2. I want to choose 3, or maybe I want to choose all of them. Well, guess what? You're not given that choice, right? Isn't it frustrating? And notice how you can get yourself completely distracted because you're so frustrated. You're kind of like a dog, like just clamped down on a bone, and you're not ready to give it up because you want to choose 3. And darn it, it doesn't make sense just 2, right? So notice that. But guess what? It's not up to you. In fact, the question won't allow you to choose a 3rd one, even if you wanted to. And if you choose less than what they request, they're not going to allow you to go to the next question. All right, so what did I choose? Again, I have to go with the best ones. Now, is assessing Jeff for a history of substance use, is that important? Heck yeah. But is there something even more direct? Yes. And I would argue with you, or argue, not with you, but argue for the B and C. Assess if he has ever acted violently in the past, and if so, under what circumstances. This one is super important. And this, by the way, I see a lot of like issues even in clinical real world life where, I'll often read notes where, patient denies, suicidal thoughts or urges or intentions and denies violence and blah, 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 right? And as if everything is fine. And the thing is, most violence towards self and towards others is not premeditated, not intentional. It's more often impulsive. Now, an impulse, it just doesn't come out of the blue like, some action potential went off in some neuron and wherever in the frontal lobe. No, it's usually in response to something happening in the environment. So there's usually a trigger that will lead a person who has that volatility and impulsivity to react under certain circumstances. So he can deny that he's suicidal or violent, has any violent thoughts or intentions or urges towards others. That's important, but it's completely insufficient. You have to add, the best way to find out if he can act impulsively by being triggered in certain circumstances in the future by asking if it's ever happened before. He's now 42. He's already coming down off the peak of violent, impulsive behavior, which usually occurs in teen years and early adulthood. And then, of course, we don't want to just take his word for it. So getting Laura's, kind of her collaborative information would be very, very important. Some of you also responded with the no harm contract. I think this is a fair game for the exam. No harm contracts are usually just considered useless. It's kind of like that covering your rear end, and there are very few instances where it might be helpful, and I'll tell you one of them. If you have a very long-standing relationship with a patient, and they themselves are motivated to sign a paper, a contract, because they feel that will help them maintain their commitment to no harming themselves or other people. So it's really like their own kind of tool to commit, and oftentimes to you, the clinician, like Dr. Jack, I want to sign this because I want to show you that I'm very serious about it. But otherwise, if you're doing it as a clinician, just that kind of, cover your rear end, it doesn't work, right? And last point, no harm contracts are very different, completely separate, unrelated to safety plans. Safety plans, that's what, or crisis plans, that's what you do with patients who have a history of acting out impulsively or violently or whatever, and are often getting into crisis, like patients with borderline personality disorder, and you kind of have a list of the things they can do when they feel like they are in an emotional crisis. Now, those things are very useful, but those are not no-harm contracts. All right? Next, which of the following are behavioral skill set modules in dialectical behavior management? Choose two. Anxiety tolerance, core mindfulness, interpersonal effectiveness, problem solving, or rumination control. So you see, this is a different kind of question. This is very much like a fact-based question. And by the way, that reminds me to say, if you have not watched my How Not to Fail Your Psychiatry Board Exam course, which is free, it's free to you, it's free to anyone. You don't even have to be one of our customers. You could, send your friends there too if they're taking a psychiatry board exam. If you haven't watched it, please watch it, because I think it will really. I do a lot more of that kind of like analysis and deconstruction of questions there, and I've gotten good feedback on that. If you haven't watched it, please do. I mean, it's not that short. It's, I think, over 5 hours, but I do think it's a good investment of your time. And even if you watch some of the lectures there, it'll be good. But anyway, this is one of these fact-based questions. There's not much wiggle room here. It's not based on your judgment. So, okay, good. But I notice here that some of you have to do a little bit of homework on your DBT because the correct answers did have the most responses, but we also have anxiety tolerance and problem solving, substantial answers there too. So the four modules, skill modules, are core mindfulness, interpersonal effectiveness, it's distress tolerance, not anxiety tolerance, distress tolerance, and also emotional regulation. Now, as part of these modules, there definitely is focus on problem solving and also on rumination control. Now, rumination is basically like worry, like out of control worry. So some of these skills in DBT certainly focus on, learning how to tolerate anxiety and worry, but they're not the names of the modules. They're kind of in a more comprehensive module. Okay? Simply fact-based.